Hey everybody, welcome back. My name is JT Weatherford. I'm a certified pediatric emergency nurse here to talk to you about something very important that might help you with some of the kids that come into your department, especially if you don't know kids that well and how to treat them. Hopefully this helps. We're going to talk about asthma, so let's dive right in. The first thing with asthma, let's talk about a little bit of the pathophysiology. What is it? What do we need to do to correct it? So pathophysiology with asthma, it is a hyper response to some sort of trigger. So triggers can be things like dust, pollen, cold, illnesses can also cause these asthma exacerbations. They don't fully understand why these kids get it, even into adulthood. It's not really related to like a genetic component. They think there might be some, there may not be. They don't know if it's autoimmune. It kind of points towards autoimmune stuff, but there really isn't any definition to it. In the research that I've done on it, it's difficult to figure out what exactly causes it. We do know that there are triggers that will cause it to inflame and to make it worse. So the big things are to avoid these triggers. The other ones that I didn't put in here, one that I just thought of, was cigarette smoke. This can really exacerbate the asthma, especially with the kiddos. So what happens? Say a pathogen, say a dust enters into the kiddo's lung. What happens? The first thing is the bronchospasms. The kiddos will tighten up their airways and those bronchioles will start spasming and causing constriction, and that airway tightens up, and this is because of those smooth muscles will constrict, trying to freak out, trying to protect the body, trying to get rid of whatever pathogen trigger or anything that's entering into the lungs that it thinks that shouldn't be there, and it's trying to get it out. So when the bronchus spasms, there will be wheezing and coughing. Then that's what you'll hear when you listen to the lungs. Sometimes if it's severe enough, you can hear that severe wheezing, the audible wheezing. You don't even need to put a stethoscope onto their chest and you can hear it. And then those kids are like, actually, I'm a little bit less worried about that. That's like, cool, we're still moving air through the lungs. It's the kiddos that you can't hear any movement and they're sitting there struggling, they're retracting. Those are the ones you really need to watch out for and intervene quickly, because that means their airways are shutting down and spasming. We'll talk about narrowing here in a second. I got a good picture for you guys on that. The other thing is they'll have lots of coughing. My son's got asthma, and anytime that he gets a cold, it flares up. And he will start coughing a lot, and that is just the lungs trying to protect themselves and get out whatever is causing them to narrow. So it's like the dust, the pollen, the cigarette smoke trying to protect itself there. And then like with a cold, you'll get that mucus buildup, which also causes the airway to narrow. So we'll go into that part here. This is a great picture of what a normal lung looks like. That normal lung there on the left-hand side there is what it looks like. That's just like me talking right now, although I've got a little tickle in my throat. I don't know what's going on there. I got something going. But that's what a normal lung looks like, and you're able to breathe in deeply, and you don't have any problems moving air through your lung. When an asthma attack happens, you can see there on the right hand side there that airway is going to narrow. If you want to know what an asthmatic feels like, just try to walk. You don't even have to walk very far. Walk like say 20 to 30 paces, but you can only breathe through a straw. So take a straw and go walk 20 to 30 paces up and down your hallway a couple times, and just walk. And then you'll feel, and the caveat is you can only breathe through that straw. You cannot breathe through your nose. You cannot open your mouth. You put your mouth around that straw and breathe through that straw. That'll give you a good representation of what an asthma attack feels like. Then if you try and run up and down the hall, you'll feel an acute asthma exacerbation. And that's why these kids really have a lot of anxiety around this, because it is really tough to breathe and it scares them. So, and we'll talk about anxiety here in a little bit as to how you can help with those kiddos so that way they don't freak out and make things worse. So that's kind of some very basic pathophysiology there. The next thing we're going to do is talking about symptoms. So what kind of symptoms can you expect with asthma attacks, just asthma in general? The big ones is you're going to have the wheezing, you're going to have the trouble breathing, and with that comes into play of like retractions. If you have severe enough asthma exacerbation, you're going to have those retractions. So you're looking at those intercostal muscles. So by the clavicle, intercostal, you're having the subcostal and substernal there, and then the suprasternal. If you are seeing any of those, that means that there's a good chance that this kid is they're compensating, but also they're progressing to where they could be decompensating pretty quickly. And you need to intervene and to help them feel much better. The coughing is just them trying to open up their airway. It's popping up those alveoli, trying to open up those airways so that way they can get more air into the lungs there. What we were talking about just a little bit ago was the anxiety. The big thing is keep these kids calm. It's very, very difficult to do this. So don't freak out. Even you can freak out mentally. That's totally fine. But don't let them feel your anxiety as well because they're super sick. Let them just reassure them, speaking in a calm tone. Do not rush to do things. Unless they're actively like not breathing, then yes, absolutely rush and do things and get to breathe for them, start CPR, all that kind of stuff. But if they are working up and getting more and more anxious, you've got to talk them down and settle them down. My son, to give you a story, my son just recently had an asthma attack. He got a cold, and that's one of his triggers, flared up his asthma, and he went to go get his albuterol so that way we could give him a couple of puffs to help open up that airway, which we'll talk about. But then he started freaking out because he started coughing and having a coughing fit and got super, super anxious. So my thing was just like I talked him down and just really focused on him and him alone and just got down at his level and said, "You're okay. You are fine." Slow, deep breaths. And just coached him through that. That is a huge thing with these kids. You really got to coach them through these things because they're scared. They don't necessarily know, especially if they're not diagnosed with asthma and have never experienced this before, and they're having new symptoms like this. You want to be able to talk them off that ledge there and just to be calm with them, be very direct. And it also depends on the age as well. So my son's 7 years old right now, and he understands enough that I can tell him, just be like, "Hey, you're freaking out. That doesn't help. You got to calm down," and just walk them through step by step and just be like, in through your nose, out through your mouth, and breathe. And that helps them so that way those airways don't inflame and get worse and spasm even more, so that way it can open up for them to be able to breathe more. So those are kind of some of the symptoms there. So what do? Well, we got to determine the severity first. So that's going to be your first thing. I did put a couple things there on the side there, the nebulizer, the oxygen, and the coaching there. But ultimately, you got to determine the severity. And how do you do that? The way that we do it, and the way that I've always done it, is what's called the PAS, the PAS score, Pediatric Asthma Score. So on here, you can see you're first going to look at the respiratory rate. So how fast are they breathing? Are they breathing 60 times a minute and they are 2 years old? If so, they get 3 points there on the far right hand side there. Greater than 40, they get 3 points. If they are breathing 30 times a minute and they are a 6 to 12 year old, they're going to get 2 points. So you can kind of see how it's broken across on the table there based on age and then how fast they're breathing. You kind of plug in their respiratory rate and do count a good respiratory rate. Do not count the 6 seconds. Do not guess. I know we've all done it. We're just all like, "Oh yeah, that's about 24. With these asthma kids, you really got to get a good respiratory rate. So do at least 15 seconds. Ideally, if you've got time, do 30 to 60 seconds. And actually get a good respiratory rate. So that way it helps you get an accurate asthma score on here. So that's your first step. Check out your respiratory rate. The next one is, what's your O2 sats at on room air? Do they require oxygen? If they're greater than 93%, then they get a 0. If they are 89 to 92% or needing less than 2 liters via nasal cannula, then they get 1 point, sorry. If they go to 85 to 88% or needing 2 to 4 liters nasal cannula, they get 2 points. If their SATs are less than 85% or needing high flow nasal cannula, BiPAP, something like that, then they get 3 points. So you can see how the progression of the severity on here. So if that kid that I said earlier, there was a 2-year-old breathing 60 times a minute, there's 3 points. And then their SATs are at 84%, there's another 3 points. And then at the end, you just add everything up on here. And that gives you your severity score. The next thing after you do the O2 SATs is going to be your breath sounds. This is where you actually listen to them with a stethoscope, auscultate those lungs, kind of see where they're at. If they're normal, breathing good with good aeration, they get 0. If they just have that slight wheeze at the end, that we call it the end expiratory wheeze, when they breathe out and you just hear that little faint wheeze at the end, that gets them 1 point. If they have diffuse expiratory wheezing all throughout, then that's 2 points. If they have biphasic wheezing, which is breathing inspiratory and expiratory wheezing, that's an automatic 3, or if there is decreased air movement. So we call it diminished breath sounds. If you cannot hear air moving, reposition your stethoscope first, and also make sure you've got the bell on the right side, because I know a lot of those stethoscopes have the pediatric side and the adult side. Make sure that that's correct. And then if you still hear diminished breath sounds, especially if it's all throughout, then that's an automatic 3. So if that kid that I had earlier was breathing 60 times a minute, there's 3 points. 84%, there's another 3 points. And I don't hear much air at all moving, that's another 3 points. So we're up to 9 points now at that point there. The next thing you're looking, lift up the shirt, look at their chest. Do they have retractions? Then this is how many retraction sites do we have. If they have 0 retractions, that's 0 points. If they have 1 site retractions, it doesn't matter where the retractions are at. If there's just 1 site, it's 1 point. If you have 2 sites, it's 2 points. 3 or more, or even nasal flaring, that gets you 3 points. So again, that kiddo, that 2-year-old that's breathing 60 times a minute, 3 points. 84%, 3 points. Diminished air movement, 3 points. And then he's retracting 3 different sites. You got intercostal, subcostal, suprasternal, 3 points. So we're up to 12 points at that point there. Okay, almost there. You got one last one. You're going to look at your dyspnea or the general appearance. If they're less than 4 years old, that gives you kind of a guideline on there. If they're normal feeding, vocalizing, and they're playing, running around the room, that's 0 points. If they have just one of the following, they're irritable, they're tachypnic with activity, or they have decreased activity or decreased PO intake, that gets you 1 point. If they have 2 of those, that gets you 2 points. And then if they have 3 of those, then that gets you 3 points. If your kiddo is over 4 years old, it's a little different. We have them count. So can they count to greater than 9 in one breath? 1, 2, 3, 4, 5, 6, 7, 8, 9. Something like that. If they can do that, then they get 0 points. If they can count to 7 to 9 in one breath, so 1, 2, 3, 4, 5, 6, 7, 8, 9, and have to take that breath in that 7 to 9 range, then they get 1 point. If they are doing, can count to 4 to 6 in one breath, 1, 2, 3, 4, 5, 6, 7, 8, then that gets them 2 points, so on and so forth. Then the 3 points is if they can only count to less than 4. So if they're going 1, 2, 3, 4, 5, 6, something like that, then that gets them 3 points. So, okay, let's go back to my example of the 2-year-old. So you have him breathing 60 times a minute. That's 3 points. He's breathing, his SATs are at 84%. That's another 3 points. And then he has diminished air movement. That's another 3 points. And then he has 3 sites of retractions. That's another 3 points. Then he's also irritable. He's tachypnic. And he is not wanting to drink or anything or interact at all. That's another 3 points. So total, your highest score that you can get on here is 15 points. 3 times all 5 of those there, that gets you 15 points. If there's variations there, so say that he's only breathing 36 times a minute, but everything else is a 3, that puts you at 14 points. So you just add them up. And then the higher your score, the more severe you are. The lower your score, the less severe you are. Then that dictates as far as your treatment goes here. So that's kind of severity. That's an easy way to look and see how severe your patient's asthma is and what you need to do immediately, or do you have time to kind of wait around and get things lined up there. Okay, so you determine your severity. Now what? You got to go to your rescue medications. So your rescue medications are your bronchodilators. Albuterol and Atrovent is a super common one. Usually those are combined together. They work together to decrease that bronchospasming and then also dilate those bronchioles and the bronchus. So that way you get all that air moving into the lungs there. The way we do it with kiddos is with a nebulizer. There's a new machine out there as well called Aerogen that is super cool. If you get a chance, look it up. We just implemented it at our location and it's amazing. So use the Aerogen or use a nebulizer as well. The way it's usually done is 3 back-to-backs. So you'll do albuterol Atrovent combo and you're going to do 3 nebulizers. You'll do 1 nebulizer, reassess your patient, get a full set of vitals, then do a second nebulizer, stop, reassess your patient, another full set of vitals, then a third nebulizer, and then stop, reassess your patient, full set of vitals. After those 3, that kind of determines where your patient is going to progress. Did they get better? And then do another pass score. After each nebulizer, you're going to do another pass score. This kind of helps determine where you're going at with your severity. Are we still trending up on our pass score, or are we starting to trend down? Because if you're trending, ultimately you want to trend down. If you're trending up even after the nebs, something isn't right. Either your scoring isn't right or your kid is really deteriorating rapidly and you need to get a provider involved. So after each neb, you want to do a pass score and a full set of vitals and a good respiratory assessment just to kind of see where they're at. If after the 3 nebs, they're down from a 15 down to, let's say, a 7 on their pass score. The lowest you can get is 0, right? So then you want to kind of see where they're at there. If they're still at a 7, they're still mild asthma there. They need to be monitored to kind of see if they progress and if they are going to need more nebulizers and nebulizer treatments to see if that's going to help or not. If they are still, so say you do 3 back-to-backs, you started at a 15 on the pass score, and then they only drop down to a 12 on the pass score, more than likely your provider is going to order a continuous nebulizer. Then what that means is that they're going to get an hour of albuterol on a nebulizer. If you have respiratory therapy, this is great to get them involved because this will help you tremendously if they can take over and manage this kid for you. That frees you up to do your other patients and stuff. But if you don't, this is going to be on you to set this up as the nurse. You want to do, so you do all your back-to-backs, they take anywhere from 5 to 10 minutes per nebulizer. So you're in there from anywhere from 15 to 30 minutes just doing back-to-backs. Then if you do continuous, once you get continuous set up, then it's just assessing your patient every so often and following based on your local protocols to see how often you're going to reassess your patient. I would personally be reassessing at least every 15 minutes just to kind of see how they're progressing. Are they getting worse? Do we need to do more than just continuous, or are we getting better and it's doing what it's supposed to do? When you're heading down continuous, there is also a likelihood that your provider is going to order an IV. This is in preparation for admission to the ICU and then also to get IV magnesium. IV magnesium is another dilator of all the bronchus and bronchioles, so that way they can get more air movement. It relaxes the smooth muscles. The number one thing to watch with your magnesium is it's a double verification for us, so you need another nurse to check it because it's a high risk medication. But then the other thing you need to check too is to monitor their blood pressure. If you start giving mag, think back to your OBGYN days. I know y'all love that. Think back to those days of when they gave magnesium to the pregnant moms that were having high blood pressure. What were you watching for? Right? You were always watching that blood pressure to make sure they didn't become hypotensive. So same thing with the kiddos. It works the same way. You got to really make sure that you don't drop that blood pressure down there. So those are kind of the immediate rescue medications that you're going to need to help these kiddos here. The next thing is your steroids. Steroids are going to be what's going to help reduce this inflammation long term. The most common steroid is going to be your corticosteroids. We used to do prednisolone at my location. We switched over to dexamethasone. They both work equally well. I think the theory behind it was that prednisolone liquid tastes terrible. It's like this lemon flavor. And then almost every single kid that I had that I give it to would puke it up, and then we'd have to redose it. So then they switched over to dexamethasone, which comes as a liquid or as a pill. And if you crush the pill up, just mix it with some water. And I add a little bit of Kool-Aid into it, and that helps it taste better. And I haven't had a single kid puke up the Dex. So it's a lot better. But the dexamethasone, you need to get that on board pretty quickly. Even if you have to stop a nebulizer treatment, give them the steroid. That way it can get on board and helping with it to reduce that inflammation. Because ultimately that's what the kids need. That's what is going to help these kids feel better. The rescue medications, that albuterol Atrovent, is just an immediate relief. And that's just to open up those airways so that way they can breathe. The steroids is going to be your long term there, and that's what's going to help them in the long run there. So that's kind of your immediate treatment there. So this is your asthma. So hopefully that helps you there, and to kind of get, trying to shut that. There we go. Trying to get that shut off there. So I don't have that right in my face there. So hopefully that helps you guys to kind of understand some basics of asthma, what it is, the pathophysiology behind it, the treatment for it, and also some common symptoms that you're looking for. So when that kid walks into your emergency room, when you're sitting out in triage, do you feel confident enough to be able to take care of them and kind of anticipate the orders that the provider is going to be putting in? Hope that helps. As always, make sure you follow your local protocols because they are different. Just make sure you know your standing orders and everything. This is just kind of some of my history and stuff there. So hope this helps you guys to understand the asthma. And if you like it, give me a like, give me a thumbs up, and make sure you subscribe as well. So I got more videos coming and more things in the works. I've got lots of stuff that I want to talk to you guys about and hopefully help you guys so that you are much more confident in your pediatric care. Thanks. Have a wonderful day.